Alright guys, this is the second video on cranial ultrasound. In this video we're going to be talking about cranial hemorrhages, germinal matrix hemorrhages, and other types of hemorrhages. So bleeds are probably the most common reason why clinicians ask us to do cranial ultrasounds. Most commonly we're looking for germinal matrix hemorrhages in preterm babies. We also do cranial ultrasounds evaluating for hemorrhages before a patient goes on ECMO or looking for bleeds while they're on ECMO. Rarely we may also be looking for hemorrhages as a cause for seizures in babies or apnea, feeding problems, things like that. So germinal matrix hemorrhages are by far the most common thing we're looking for. Just a little background, the germinal matrix is the cellular, very vascular area in the baby's brain during development where the immature neurons are born, and then as the baby develops, the neurons migrate out to their eventual normal position in the brain. The germinal matrix basically lines the subependymal region of the lateral ventricles on both sides, and the reason that they are prone to hemorrhage is they have very fragile blood vessels that can burst if the baby's under stress, like fluctuations in blood pressure or other stresses. The germinal matrix is greatest in extent at about 23 weeks of gestation, but then it eventually gradually involutes and goes away. So by about 32 weeks it's pretty much confined to the caudothalamic groove that we discussed in the previous video, and basically by 36 weeks it's completely gone. So that's one of the reasons why germinal matrix hemorrhages are very unusual in term babies, because this structure has basically resolved or involuted by the time they're born. So risk factors for germinal matrix hemorrhage include prematurity. 2/3 of babies under 32 weeks of gestation will have some form of germinal matrix hemorrhage versus only 5% of term infants. And also another risk factor is very low birth weight. As far as when the hemorrhages occur, the vast majority will occur within the first 3 to 4 days of life. So 50% occur on day 1, 25% on day 2, and 15% on day 3. Clinical signs include decrease in hematocrit, abnormal neurologic exam like decreased consciousness, seizures, apnea, etc. Up to half of them may be clinically silent, though, without any overt symptom. So the algorithm that the NICU here at UK uses about when to image these babies, if an infant is born less than 32 weeks gestation, based on their algorithm, they'll obtain an initial head ultrasound usually at about 7 days. If that is normal, then they'll do a follow-up at 1 month or whenever the patient is discharged. If it's abnormal, though, on that initial head ultrasound, they'll usually get a weekly follow-up to assess how things look. And of course, they frequently obtain these cranial ultrasounds off schedule or earlier, depending on if they think something is going on more urgently. There's the grading system to germinal matrix hemorrhages. It's called the grading system of Papille. It's from 1 to 4. We'll go over that briefly. Grade 1, which is the most common subset of hemorrhages, is the most mild. It's confined to the caudothalamic groove, and this represents 40% of all germinal matrix hemorrhages. Grade 2 means that you have hemorrhage that has spilled into the ventricles, but hydrocephalus has not yet developed. Grade 3 is basically the same thing, except now the baby has hydrocephalus. And a grade 4 means that there is parenchymal hemorrhage within the brain matter itself. So the importance of this staging system is not that a neurosurgeon is going to go in and evacuate this hemorrhage or they're going to do something about the bleed. It's more to give the clinician and the parents some idea about the prognosis for the baby. So the higher the grade of hemorrhage, the higher the risk of the baby dying is, and if they do survive, the higher the risk that they're going to have significant long-term disability. So a grade 1, a very small bleed, usually has minimal, if any, disability, has very low mortality. Grade 4 hemorrhages, on the other hand, have a very high mortality and also a very high risk of long-term disability. So a few examples of these hemorrhages. This is a classic grade 1 hemorrhage. You can see the arrows on the coronal and sagittal images pointing to abnormal focal echogenic material that's in the caudothalamic groove, and that's basically a grade 1 hemorrhage. There was no other hemorrhage anywhere else to give it a higher grade. Another example of a small grade 1 hemorrhage on the left in this patient. We see an asymmetric echogenic area, again at the caudothalamic groove, on both coronal and sagittal images, and this just again represents a small grade 1 bleed. This is a good example of what can happen as that grade 1 hemorrhage ages and the body starts to break it down. Sometimes what we'll see is a little cyst develop. So you see the small cyst that's at the caudothalamic groove. There's no blood flow on Doppler image. And this represents an older hemorrhage that has undergone some breakdown. This is an example of a grade 2 germinal matrix hemorrhage. Remember that babies are laying on their back most of the time. And so if you have blood that spills into the ventricles, it's going to float down by gravity to the lowest position. And in the brain, that is the occipital horn of the lateral ventricles, which is back here. So we can see in this patient that this area that the arrow is pointing to, which would normally be filled with dark CSF fluid, is filled in instead by an echogenic blood clot. But notice that the ventricles are not enlarged, so the patient does not have hydrocephalus, so this is just a grade 2 bleed. Another example of a grade 2 hemorrhage. You can see that there's echogenic material filling the lateral ventricles on both sides, and we can see that on the sagittal images here as well. We have some bleed at the caudothalamic groove, but also extending into the ventricle itself. We see that here as well. But notice that the ventricles are still small and normal in caliber, so there's no hydrocephalus at this point, so this is a grade 2 hemorrhage. Grade 3 hemorrhage means, again, that you have blood in the ventricles, and now you have hydrocephalus. So you notice that there's a large clot here on the left side. Again, we see that in the occipital horn of the lateral ventricle, again because the baby's laying on their back and that blood layers down by gravity. But also notice that the ventricles are mildly enlarged. So this is a grade 3 hemorrhage due to the interventricular blood as well as hydrocephalus. Here's an example of a grade 1 hemorrhage on day of life 1. Again, we see abnormal asymmetric echogenicity at the caudothalamic groove. That's a grade 1 hemorrhage. But after the patient's condition deteriorated on day 3, they ordered a rescan, and we can see that the bleeds have significantly increased. On the right side, now we have a large hemorrhage that's spilling into the ventricle. And you notice that the ventricle is enlarged as well, so there's some hydrocephalus that's developed. So on the right side, this has turned into a grade 3 hemorrhage. On the left side, it's even worse. You see, obviously, that there's a big hemorrhage that's occupying the lateral ventricle, but also we see some new parenchymal hemorrhage. This is hemorrhage in the brain matter itself adjacent to the ventricle. So this is a grade 4 hemorrhage on the left. And then this is what happened to that bleed a couple months later. The body will break down that bleed and kind of liquefy it and reabsorb it. And often when there's hemorrhage in the parenchyma itself, it turns into these cystic spaces. So we see several big cystic spaces on that side. Another example of a grade 4 hemorrhage. We see on the right side there's some blood products within the ventricle itself, but again we see some asymmetric, ill-defined echogenicity in the periventricular white matter on the right, which represents some grade 4 bleed. Another example from a website listed below. This is early in the course. We have this parenchymal bleed on the right, and then down the road, several months later, that's been turned into a large cystic space that communicates with the lateral ventricle on the right side. choroid plexus hemorrhages, these are often questioned, and the choroid plexus hemorrhages can be a difficult thing to determine because, as I mentioned on the last video, the choroid plexus is normally a very echogenic structure, and it can be somewhat irregular, and it can also have features like this, which is a cleft, that can make it confusing and difficult to determine if there is a hemorrhage. Probably the best method to say whether there's a choroid plexus hemorrhage is to see if the choroid plexus on one side is significantly asymmetrically larger and more lobulated and irregular than on the other side, and also if the echotexture is very heterogeneous or irregular looking. That would be the best indication that there is a hemorrhage within the choroid plexus itself. Oftentimes, though, all that we can do is see how it looks on the follow-up and see if those findings are stable or if they've changed. If they've changed and evolved over time, then we can be more confident that it was a choroid plexus hemorrhage. Some other hemorrhages that we encounter, one of the big ones is ECMO, which stands for extracorporeal membrane oxygenation. This is used in a wide variety of settings of respiratory failure, but most commonly it's in meconium aspiration and persistent pulmonary hypertension. The reason that this is important is that as part of this treatment, the patient is put on blood thinners or put on heparin to prevent blood clots forming in the ECMO machinery. And of course, when you're anticoagulated, this will make it easier for you to bleed and bleed into your brain. So normally the clinicians will ask for a pre-ECMO stat ultrasound. This is to assess for any contraindication to ECMO, like a pre-existing bleed or mass. And then we'll also get a daily head ultrasound looking for any hemorrhage that's developed. If the baby develops a hemorrhage while they're on the ECMO, then the clinician has to decide whether they have to stop ECMO or reduce the heparin or do something different. The reason that these are important is that everyone's pretty familiar with looking for echogenic hemorrhages on cranial ultrasounds, but bleeds on ECMO due to the anticoagulation can be hypoechoic instead of hyperechoic. The reason that bleeds look hyperechoic in the brain is because of the fibrin mesh that forms within a blood clot. It has a lot of reflective surfaces that causes it to look echogenic. But when you're heparinized and anticoagulated, you don't form that fibrin mesh within a clot, and so your hemorrhage stays hypoechoic. Another important note is that hemorrhages can occur anywhere, not just the usual places that you're looking for germinal matrix hemorrhages. You have to look anywhere in the brain for a bleed. So this is one of the examples that we had here at UK of a patient that had a hemorrhage on ECMO. You see the pre-ECMO ultrasound looks pretty normal. Shortly after ECMO was started, however, the patient developed this hypoechoic area in their cerebellum. The next day looked about the same, but a day and a half later it had gotten larger. So this was a hypoechoic hemorrhage. In case you don't believe me, the patient got a head CT which showed this large. This was a couple days later, but still the hemorrhage had continued to enlarge. This was their MRI showing this very large hemorrhage within the cerebellum. So remember, we're looking for hypoechoic bleeds in addition to echogenic bleeds. Remember, they can occur anywhere. This was a different patient in the PICU that had liver failure, and because of the liver failure, they had basically anticoagulation as well. And this patient had just dozens of hemorrhages scattered all throughout their brain. Again, not in your typical locations for germinal matrix hemorrhages. These were all over the brain in various locations. This was another unusual hemorrhage. This was actually an extraaxial hemorrhage, meaning it was outside the brain itself. This was an epidural hematoma that was in a patient that had hemophilia. And this is the corresponding CT that show this big hematoma that's pressing on the brain. Here's a nice example of a cerebellar hemorrhage. This shows you one of the advantages of the mastoid views. So we get much better detail of the cerebellum. We see this focal echogenic area here, had no blood flow. And then following up 1 week later, we see that hemorrhage has evolved and become hypoechoic, just like we expect hemorrhages to do over time. So that's it for this talk.